I'm looking at the soft tissue, and basically I divide the soft tissue into interproximal and the focal soft tissue. So the first thing I'm going to do is to look where is the focal soft tissue. As you can see here, there is a recession, here is almost level. And then I look at the interproximal soft tissue. The more the soft tissue is in there, and is level, and we have papillas, it's an easy case. The more I have lost the papilla, it's a problem. Okay? So there are many things to take into consideration when we talk about diagnostics. This is only from the frontal point of view. Both of the cases are coming to have an implant done on the central incisor. But there are many other things that I take into consideration. The lip line, how much the patient shows, the type of tissue, the type of bone, the orientation of the tooth, the thin biotype, thick biotype, if the tooth have crowns or not, if they are natural teeth. So there are many things that take into consideration before I decide what to do. But every time I have lost the interproximal bone on the tooth that I need to extract, and I have lost the bone next to the tooth, usually I don't place an implant. Why? Because it's difficult. I will never get the papilla. So what do I do in these cases? When I have lost the papilla next to the tooth that I'm going to extract. Why is that? It's because this papilla will never support the bone. Okay? The bone on the adjacent tooth is the one that is going to support the papilla. As soon as I extract the tooth, I will lose the bone, but if the bone has been lost on the adjacent teeth, it's a problem. I will never place an implant in here. Why? Because it's difficult to come back with the papilla. So the classification is wide, and this wide I would go vocal, interproximal. Vocal can be ideal, it can be bone recession, you have a nice soft tissue scallop, but lost bone. Here the distance, the maximum is 5 millimeters. If I go beyond that, I reconstruct the bone. I will show you some cases. And we have cases where we have beautiful soft tissue, but no vocal bones. And I have situations where I have lost, I have a vocal soft tissue recession with the bone recession, and I have vocal bone gone and with the recession. So I have a bigger problem here. I have to reconstruct the bone, and I have to reconstruct the soft tissue height. Okay. So there are many difficulties in different situations. But the worst are when it deals with interproximal. You can have a bone defect with nice papillas. It can be unilateral or it can be bilateral. The tricky and trap ones, because you can get fooled, or if you don't know that the bone is in there, as soon as you extract the tooth, everything will collapse vertically. Or you can have a worse situation, bone loss unilateral with papilla loss, or bone loss. Okay? So let me share this one. This is 2013. After orthodontics, what would you do? It's coming, having implants made. They did orthodontics on her. What would you do if you're a periodontist? Would you place implants on this patient? No fucking way. You know, if I was an Italian, some Italians what they do is they extract teeth in order to level the bone in the proximal. But if you fail, you have extracted good sound teeth. No way I'm going to place implants in here. First of all, it's periodontal competition. So in this case, what I do is the bridge. I do a 6-unit bridge and finish it. You can see the bone defect. Here we did many things. I did some extrusion beforehand to bring the soft tissue. The best surgeon in the world is your orthodontist, because you can extrude the soft tissue, so it will be much easier. We did 2 times connective tissue graft. We pulled. I didn't have enough soft tissue. One of my bigger mistakes here is that I intervene too fast. Every time I place bone, xenograft material, at least I wait 8 months before I go back and start pushing the tissue. Here I waited 4 months, so the bone is mushy poo-poo, so it's moving around. So I had to go back and graft again. Okay. So I graft from the palate. Everything is tunneled, and in the afternoon I will discuss how we do it. Basically, everything has been tunneled. The tooth has been positioned exactly where we wanted, and we push to the ground. And 4 months later, is the final pontics. I don't do avoid pontics when I have one pontic next to the other. It's a waste of tissue. So if you have the volume, it's a little bit of a rich lap. Everything is by pressure. So I do many things differently from what I was taught. Because if you want to do avoid pontics, more than 3 avoid pontics one next to each other, you need way too much volume of tissue. But with one, it's okay, but more than one, it's a problem. It's not the topic, but it's where we started, where we finished. So you have 2 pontics in a row, with papilla in the middle, and the situation. What about this one? This is a trap. What would you do? Only if there's an implant in here, right? The tissue proximal is gone. And we do the ridge preservation. It's 2 years down the road. No matter what you do, you have a collapse. So we do connective tissue graft. You can see the papilla is level, very much. Fistula, crown. What do I do? Simple, predictable. An implant in there, in between crowns, is a pain. And then you will have an implant of the teeth, which is a class 2. So the bridge sometimes makes it better. But let me look at interproximal bone loss. Usually, if the interproximal bone loss is in between 2 teeth, it's okay. But I can place implants. But if the bone loss interproximally is in between a tooth and a tooth that is going to stay, it's a problem. But if you have the bone defect in between the unilateral bone defect in between 2 teeth that need to be extracted, maybe it's possible. This one. Not an easy one, because on top of that, she is a dentist. So what would you do? Okay. This is the situation. This is, it has no bone on the vocal aspect, no bone here, resorption, resorption, no bone, no in the proximal bone. They try to get rid of the resorption, but those teeth are totally gone. So, difficult ones. So what would you do? Well, I would do implants on both central incisors. But I will do something before the implant, which is connective tissue graft. Why is that? Well, I'm going to try to see if I can improve noticing all the bone defect and bone problems. I'm going to try to place a provisional restoration on both teeth, create more space, and do a connective tissue in between the teeth. Because doing a connective tissue against the tooth is easy. Doing a connective tissue against an implant is much more difficult. So in those cases where I have a defect, usually I do a connective tissue and I don't have a papilla height. I'm going to try to do a connective tissue before extracting the teeth. And then try to set ideal soft tissue before planning the implant. So this is the provisional. I did a provisional with pink composite. To have an idea how long those teeth were going to be, if she liked it, and then decide how much I have to advance the soft tissue coronally, and how much I can thicken. So this is the situation, and this is the first connective tissue graft. So usually, the way that I do connective tissue graft, I do always an incision crestal, and I do a small incision on the above the fornix, on the ribs, and from there I'm doing a full thickness flap, just to elevate my flap. The problem is elevating the flap in between the two teeth. So I brush, I try to create elasticity of my tissue, I create a space, I create a space in between the roots, I go palatally, so my tissue can move from vocal to palatal. I elevate the papilla without breaking my flap. And then what I do is I do full tuberosity in between the two teeth. I came from the back, going to the tunnel. You can see here I have the defect as we saw. Everything has been cleaned with laser. And then we're going to bring the soft tissue in between and tap it out. Okay? So I'm pulling from the palatal and I'm bringing the tissue proximally with the finger, I'm pushing it exactly to suture it wherever I want. And then I will suture the vocal aspect to thicken the soft tissue as much as possible in order to maybe in a second connective tissue increase even more the thickness of the interproximal. So usually when I have this type of cases, I try to build as much tissue thickness maybe in 1 or 2 surgeries before I go back and break my implant. So I will easy go through, and then all the excess, the idea is to level it out. All the excess, all the tissue that is sticking out, I'm going to modify it. I'm going to cut it. I'm stabilizing the vocal connective tissue. simple, nothing complex.
khá là đơn giản, không có gì phức tạp.
Sling suture
Với đôi tay của thầy
coming
này,
around the tooth,
cái này mình đang khâu mũi treo,
suturing against the root,
khâu mũi treo nó phải áp sát cái mũi
bring
rất là
it
cứng rắn.
into the position.
Mình chồi nó về cái chất này một chút.
The flap is able to move
Hai
vertically.
cái bàn nó có thể nó
And
thể
this little excess, I take all the composite off. I identify and count both. And then what is sticking out, just move sideways, even improving more the papilla. And figuring out how much volume I want and position. Okay? What is important also is the traction of the soft tissue. I hate Marcus Uster suture. I use things that are much simpler. I use a suture from Gerardo Chacon, who is a guy from Venezuela who lives in Colombia. It's really simple and you will see it right away. It's a simple, if you want to take some contact points, and if you want to bring both papillas, I take palatal and mesial papilla and I suture. I put my finger, come from the palatal, I take my papilla, it's a single, what we call the reverse single. I learned it from him. Really simple, it's just for people. Put the finger, I want more pressure, if the tissue is movable, you can bring the tissue, we go to the line angles, we push it again, you go to the other line angle, and you push it. Okay? Really simple. You concentrate the contact point and the suture. You can take either the palatal or only the buccal flap, depends what you want. So really easy, really convenient. This is what it looks like. So this, how it looks, is about 2 weeks. Nice cleaning. Where we started, provisional, 2 weeks. And then when he comes, I was pretending to do a subconnective tissue graft. She tells me, Iñaki, I have a problem. Yes, I have a fistula here. Rating, bad pain. I said, well, maybe I have to jump into the implants because there's too much infection here. If I will connect the subconnective tissue graft, I can risk to have a problem. So we decide to place the implants. Okay? You can see I placed the upper cam marker here. Nothing. You will see. So I'm plugging implants 3.5 into the implants. And the other issue is the more I'm placing my implants deep, the more I'm thinking on the transmucosal abutment. Why is that? Because if I want to increase the bone vertically, I don't want to be disturbing the connection of my prosthetics with my implant head. So I always use transmucosal abutments, multi-unit abutments. Okay? So let me share with you the surgery. And this is the surgery of the implant placement. So the patient has had already one connective tissue, those teeth are totally brittle, they break, they are totally in bad shape. Okay? So I'm pulling with my finger, you can see all the cracks, all the situation of these teeth. I'm just pushing, you can see the resorptions and how much infection we have in them. So I de-epithelialize the sulcus, really important, because if you don't do that, you will have scars. I use whatever is in my hand to disinfect, clean, not only the bone, but also the soft tissue from, I use also carbide, everything have into my hands to make sure that I got rid of all the infection. Okay? Not only from the inside, also from the outside. I deepthelize, you can see the prolapse. I don't have the proximal bone cervically. I don't have palatal bone, so I will have to reconstruct buccal and palatal. So here we use a membrane from pigs. I use the one from Osteobiol, it's called Lamina Soft. It's about 0.8 millimeter in thickness. It's a rigid, semi-rigid membrane. So I will do a cut of my periosteum at the base and a cut at the periosteum vertically in order to have all this soft tissue moved. So this is the membrane that goes on the palatal aspect, and this membrane will go on the buccal aspect. So the membrane is tagged through those little holes into position to reconstruct my bone. This is from Osteobiol, and then I close it, and then I will place my implant, just one burr, to place my 3.5 by 15 millimeter implant. Maybe I will engage a little bit the penetration, or even 7 millimeters. So my implant knows where it should go. I check if I will place the bone in between the membranes. You can see one in the buccal, one in the buccal, one in the palatal, in the middle. I will try to now create a little space of where the implant will go, inside water, of course, and then place my implant and try to get the 70 Newton. I'll go and then figure out how deep I want those grafts to be. Usually the depth is 5 millimeters, 2.5 for my multi-unit, and another 2.5 for my connective tissue. So I'm packing bone all the way up to my implant, and once I have packed my bone all the way up to my implant, I'm going to pack bone all the way up to my transmucosal. It's a lot of work, and then once you have done everything, you will line your provisional and maintaining the emergence profile desired. Take it out, and now allow space for 2.5 millimeters of connective tissue. So this is a double trouser, one from one side, the other one from the other side. The thicker tissue will be in the middle. And we go from the outside in order to allocate exactly the connective tissue where we want it. So now the connective tissue has been taken from one side. Now we go from the palatal. Now we go from the distal part, buccal. So we orient our connective tissue before we insert it. Okay. So you can insert the connective tissue where you want it. Place so it doesn't go. I want the connective tissue to stay exactly where I want it. Sometimes I take advantage of my adjacent tooth to really place the connective tissue exactly underneath the papilla. So you can see the precise position of everything, so the papilla gets supported. So here is a long surgery because we reconstruct the bone. With the lamina, we reconstruct the bone with the soft tissue. And the soft tissue is the most important. So you can
Cái mô
see
mềm đó là
I'm checking with my finger,
thấy là tôi đang tra
allowing the space
cái khuôn
with my
cho
provisional.
cái khung hình tạng nó đúng chưa.
I'm taking it out. I'm just checking how much movement I still can do. If I can bring more soft tissue. So you can see I'm stuffing as much tissue as I can get from the tuberosity. This is one tuberosity. So I'm running out of tuberosity. You can see the space that is left from 2.5 millimeters. I still have to go one more surgery. It's not finished, but we'll go after it. It's not easy. Nobody has said that dentistry is easy. And then I pull everything again. Sorry, vertically on my tissue. Again, the palatal and buccal one shot. Come from palatal, buccal, and the contact point will stretch everything. I go to the line angles, depending on, you can see here where the fistula was. This is where we started. These are 2 weeks for what? I take my stitches minimum 2 weeks, sometimes 3 weeks. The ones that are on the top ones, they go away the first week. This is the scenario of a cut of what we were able to achieve. Pay attention that the bone is flush with the multi-unit. I see a totally different result with the steel multi-unit. We used to have the titanium one. This is where we started. This is the different X-ray. This is day 0. We're happy. This is 4 months. I lost some. And this is 6 months. Stabilizing and remineralizing. I will, once I get back on Monday, after my trip, I'll have the patient to do that. This is how she looks 6 months later. And of course, there are many things I would love to change. For more my provisional, okay, I would like to have an opening. I would like to increase my papilla, increase implants. I want to improve the volume. Here I have mucosa. Here I have some keratinous tissue. So I will open and the space will improve both papillas. I think it's going in a good way to success and a happy patient. So I will jump on normal relationship. And this is when I have a normal relationship, you can do many things. In the case that we did the crown before extracting the tooth. So that means that the day of the immediate implant placement, I deliver the final result. We have many cases like this. We landed, so in type 1, you can do whatever you want. You can see them with one crucial. And we do a verification jig, we do all the steps. And every time you deliver everything, same day, you see that the bone is totally undisturbed, and you have a great result. So we always make 360 degree connective tissue graft. As I've shown you, this is the final crown, same day. So all the work we've done before is in the bottom. The iPhone videos of 7 days, day of the surgery, 3 years down the road. So it works really nice. It's this section also on the GSM tools, we got rid of it, and this is what it looks like 3 years on.
ở cái đằng bên cạnh thì nó cũng đã tiêu biến.
Any other cases, internal absorption, class
Số
1,
cái ca khác thì mình có nội
so
tiêu
we did the crown before
là có dạng
doing
của
the implant. The crown here will have a little recession.
bị tiêu.
So on the recession, what we do is we do a double connective tissue graft, and I'll show you in a moment.
Bố mẹ có thể dùng
This is
về
the different videos, extraction, placement of the implant, placement of the final abutment, cementing, connective tissue graft. We use LPRF, it doesn't do anything to you.
ghép vào ở đây
I prefer connective tissue graft.
PRS ra
We did local and circular. Please don't do one connective tissue graft to do the local and the proximal. I always prefer to do the separate, meaning a local connective tissue separate and the circular. Because if this connective tissue get necrosed, you lose everything. So I prefer to do two parts, and I'll show you more cases. Those are all cases maybe now 5 or 6 years ago. And delivery of the final crown. Why cemented? Because if I have a little distortion, I can use some composite of the adjacent tissue to have a nice,
sau khi mà gắn mình xong có hơi sai một chút
the proximal contact and use the final result. It's important to de-epithelialize the surface. If you don't do it, you will have problems with scars. You can see the perfect symbiosis of the crown and cement, all perfectly everything is designed in a way that we have a perfect restoration. This is what we started, and I say 3 years is your reality. If you don't rush, you will see your problem within 3 years. So, do I do a lot of this? No, I don't. Usually it's patients that believe on me, families, easy cases. In easy cases, you can do anything. The challenge will be with implants. If I ever do 2 implants or bridge, they will be splinted or weak. I never do any more 2 single crowns on 2 implants, because I have cases where I have a diastema between 2 implants because of the growth of the suture, so always split the implant. Today, in this case, was the first. They did extrusion, they did it wrong, the wrong way, they did no sound tooth structure, so we decided to place 2 implants. And the patient was easy to handle, so we jumped everything, and the surgery, the surgery or the different stages and steps pretty much the same. Packing the bone, and most important, elevating the papilla, deep tissue, easy case, controlling the exclusion of the patient. I perforated the patient once I was doing the exclusion, checking the exclusion that both implants receive the same load at the same time. Very, very important. So shim stock is crucial, doing the pants and placing the thicker tissue where we need the most, which is the proximal. So I suture the little defect there, checking the exclusion, modifying the angulation, the angle of exclusion of the lower anterior teeth. She wanted long teeth because she was working hard on her teeth, placing the implants exactly in the same place as we have planned in the model. So you can see nothing to come up to this type of details and dexterity is not easy to overcome all the problems in the lab and clinical also. Okay? So this this is what I received. This is provisional that I did. This is the front on the teeth before placing the implants. This is 1 week after the connective tissue graft. This is the same day of the surgery. This is 9 months. This is 3 years down the road. The tissue grew. Okay. This is typical deviation. This is the bone that modifies. This is the iPhone video. This is the article. This is about 3 years down the road. And this is the look. Okay. So, this 5 years down the road, we modified the soft tissue with laser, and this is a year later, the final result. Okay. So what about when we have a bone recession with a nice buccal bone, but this recession is 5 millimeters? In these cases, I do connective tissue graft. I do not prefer to grab the bone because it's more complex, and I try to make it as simple as possible. Okay? In those cases, I will do a 260, and I also do a second connective tissue graft, which is here in the back of the bone. One round, one buccal, and every time you do this type of increasing the thickness of your soft tissue, I always modify my emergence profile to allow more space. Sometimes even I cut the abutment, the root, the same that I do once I have a natural teeth. I cut the root in order to allocate more space for my connective tissue and maybe mask my dark root, for example. And I do the same with implants. So I'll show you the case. Because the most important, I did the research with Marcus Blatt, and what his research showed you that the grayish appearance of your soft tissue at the end is only the anatomy of your emergence. The emergence should be buccal, it should be convex to the emergence profile of the tooth. As soon as you have a dissimilarity of your tissue volume compared to the adjacent tooth, you have a great appearance. It doesn't matter if you have a zirconia abutment, if you have 3 millimeters of tissue thickness, you have a problem. Okay? If you look at Ronnie Young's research that shows you that if you have 3 millimeters of thickness, your eye cannot detect if you have a titanium or zirconia abutment. Well, you have to think that there is not a lip. Those lips don't have a lip, they don't migrate. Okay? And the problem is the lip. If your patient shows the soft tissue, you have the Röhrle effect. It is more important the volume that you acquire on your tooth and your implant. If there is a dissimilarity, you will have a great appearance. So watch out. So those are cases we have done 15, 16, 18, 20 years. For example, this one is one totally independent on buccal, which is sutured with one suture. The idea is that the soft tissue is sticking out of the socket and will go under the concavity of your crown. Okay? So the crown is like a mushroom, trying to cover everything underneath. Which is covered. Okay? These 10 years. Okay? So this is the trouser, is a piece of tissue for tuberosity. What is important is to de-epithelialize the top and the circus. Usually the distal circus on the second molar. And this is a block. And you make an incision in the middle with 2 legs. You have one leg, the other leg, and it goes around. Okay? The belly, which is the thickest part, you will put it wherever you want the most. On the buccal, on one if you have an implant next to the one that you are doing. So this is the belly, and this goes around the abdomen. Okay, you have seen nothing difficult. So this is where we started. Okay, in the session, we did an internal reaching. We level the occlusion, the disclusion, the protrusive, okay? And this is the final case, okay? Nice papilla, nice volume, papillas have been kept, even though they are inflamed papillas, okay? So we go really fast from left to right, and you see here, we see all the prosthetic modifications in order to bring the tissue to more coronal position. It's only a recession of the tooth. So we divide the soft tissue into two. One will be for the buccal, one. And then another one will go around the abutment. Here we use the final zirconia abutment. And we modify the root of this tooth. You can see I'm modifying here the crown and the zirconia abutment. Okay. So, I never had any problems with how much we modify the root and how it looks like with the surgery. I will go into all of it outside. And then or we can compensate today with ASC, which is an amazing adjustment for 25 degrees. With the iPhone video. Okay. We did the internal reaching, a composite, and we have to manage this. Another one, a recession. Probably you have to bring down the soft tissue to level the soft tissue and the connective tissue on the buccal, the round, and on the distal. The problem with deep implants with Nobel is that if you want to use the transmucosal with Nobel Active, you have to go to on-one and the on-one abutment is way too big for lateral incisors, and then you cannot compensate for the angulation. So I will share with you some indications where I use what. Here everything has been modified with, you can see the ASC is way too big and too close to the implant head, so it creates pressure on the adjacent tooth. You can see 1 year later we have lost the bone to the pressure of the tail base. So this is the reality when we finish, usually it's full contour. So let me show now difficult cases. The recession where there is no bone on the buccal aspect. Okay? I have a nice scallop, but there is no bone. So there are all infected sites. Of course, there is one that it's impossible to get to implant placement, which is this guy. There's no way I can anchor here. The nasal nasopalatal nerve, there is no possibility to anchor, so I have to do a delayed approach. And we'll talk about this in the afternoon. It's not immediate anymore, but the rest, these the best articles out there talking about PCS and infected sites, and they come up with similar cerebral veins. I don't like the pictures of what those guys are doing, but it's true that you can do it. I started in 2020 to place immediate implantation on infected site where there was no focal plane, no palatal. The only problem that is you need to look at which is the situation of the relationship between the tooth and the housing of the bone, the alveolar bone. So here, in all of those three example implants, you can still have bone to stabilize the implant, but in this case it's impossible. Okay? So we need to know which situation is possible, which one is not, and the classification from Joseph Kahn really helps to have an idea. Of course, this is a delayed approach, to have the structure tooth. I will show you that case tomorrow. Basically, it looks like when I placed it, this is 7 years down the road, how it looks like. Just with soft tissue. So you can see 7 years down the road. There is two ways of getting rid of reconstructing the bone. These techniques that I know. One is from Jose da Rosa from Sao Paulo, great surgeon, who uses the bone from the tuberosity to wedge it between the implant and the tooth. I was using that since I met Hannes Wachtel, and I like Hannes Wachtel much better than the Da Rosa technique. And I'll show you what I mean by that, and I will go directly on what I'm doing right now. So in the case that I did that rosa, it looks this way. I jumped it here, next to an implant, 4 years down the road, with autogenous bone of the patient and lab. We wrote an article because we see we have a totally different way of doing it. The veneer next to the implant at anyhow. You can see the value is the same, and the body can detect which one is the veneer compared to the implant. But what I want is to show you. This Hannes Wachtel technique since 2015 and started in 2020. This is from Osteopiol, the Italian brand that makes membranes of 0.6, 0.8 diameter by hand, and these membranes are thick cortical. They have some flexibility, and this is due to the mineralization of the membrane. So it's kind of, when you take it in your hands, it's like cardboard, kind of. I don't usually wet it too much, because it's not when you touch them, you can break them. The results that I have got are really good, and I want to knock in wood. I have had 100% success. Okay? But you know, this is like soccer. I don't know if you play soccer. I was professional soccer when I was young. As a Spanish kid, I wanted to be a soccer player. I was not good enough, so I became a dentist. So what we do is we use this membrane to reconstruct the local bone, local or palatal, and I like to pack it. The packs that I use are from this Vancouver, two packs, some messenger, and then I use bone mixed with antibiotics. I can clean the socket with everything that I have in my hand, and I mix it. I've been mixing this for many years. I learned this from the maxillofacial department of science lips. Usually I have much less sequential using antibiotics. You can use penicillin, you can use whatever you like, antibiotics, you can use metronidazole, whatever you like, and I mix it together, and then I use this is specifically for immediate replacement on peptides. And then I use tuberosity connective tissue, especially for only when I place the implant, or as I showed you before, when I want to avoid as much collapse of vertical and horizontal on the stripe of my implant placement. And usually this is something that I'm using lately, which is hyaluronic acid. It's called Diadet PG. Julian is at the base of the research, and I like it. You don't have to, but it creates benefit. So the sequencing is based on your dexterity. Usually I start the tooth, and the original is you place the implant. Try to stabilize the implant, which is the most difficult part. If you are able to stabilize your implant, then you have all the problems solved. So every time you're going to place the implant, we pray, okay, you want to place 70 minutes, and then you don't press the button. For me, I always place the buccal lamina. I tag it, the original technique with a tag membrane, but I have much better results tagging the membrane through a little hose, as you will see in a moment. Then I place my implant and do my connective tissue graft and place my bone and my abutment and do local and circular connective tissue grafts usually to compensate the volume loss and the okay. So let me show you different cases. The case that I did a long time ago, and I finished in way. One job. He has a canine. His first premolar. He has an implant and the canine is included. So we center the midline, crown lengthening, connective tissue graft, and do crowns, and veneer, and then he came 6 years down the road, and because he fell on the bike, and what's going on here? Yeah, I saw that few months ago, and you can see all the problems. So we decided to do this, and you can see all the amount of money gone here. So we place our provisional first. I have already a thick connective tissue. So we're going to do a circular and local connective tissue to compensate all the reduction we're going to happen on the day of the surgery. So I try to do I make an incision on the medial where I think when you place the tag, I don't want to hit the hook. So try to have an idea where the tags are going to go, where is the defect. You can still see that through those little holes. I try not to engage the gingiva, the keratinized tissue, the corticoid. And just it helps you to have an idea. If you are looking, you are cleaning perfectly your site. And it allows you also to see how well you are elevating the full thickness line. If allows you with the laser also to clean from the inside and the connective tissue from the outside. So there are many, you can see the spine, and you have a better control of what you are doing. Okay? So we can place the board, the membrane, which is usually I placed it dry, but sometimes it depends the difficulty. Sometimes I wet a little bit just to be able to take it in. The membrane is just level with the digital graph. So my connective tissue has to be outside of the below my clamp and outside of the membrane, and inside the membrane around my membrane. So you can see I tapped it. I think it was the best place, and then I go through those vertical incisions. You can call it vista or pinhole, whatever you want. No vertical rinsing incisions. The vertical rinsing incisions are done from the inside. Okay. And then the suture and the rest you have seen. Okay. So we have the entrance from my membrane. I place my membrane, I take my implant, place my implant in this case. Sorry, in 2 weeks. It's my provisional that has pushed the tissue a little bit more. And it's actually my condition for analyzing the ASC. Is the video of the final result. You can see all the connective tissue will progress back with another connective tissue graft on the rest of the teeth, and this is how it looks like. We stated everything because the teeth were moving due to accident, and you can see all the volume even though we have lost. And we have a canine, we have center, the canine, everything looks again in the same condition. And where we started, where we finished, and this is a 5-year paper showing the retrospective series of cases. It's really nice. So I will jump a little bit because I want to show you a few more things. This is the repetition. Let me share this case. This is one of my first cases just to show the complexity. It's a case where I have lost vocal and palatal bones. So I have a huge fistula here, and not one of the palatal, the picture is coming up here. So I decided to place an implant, because if I don't place an implant, I will have done a pumping, because I will have done a Maryland, or maybe I will prep the canine, and I can either mesially, because if you don't do any media here, you are totally, you have lost everything. So you will have even a fiasco. You can see here all the problem, palatally, vocally, I'm planning on an 18mm implant, and maybe after very time the base of the nose. So fiscal case. What happens is the reality. I was not able to stabilize my implant. You can see all the granulation tissues coming out, the fracture all the way down. No ball whatsoever. I placed my implant to the best of my ability, but I was able to only stabilize my implant 7mm from the prefigural vertebrae. So this was a problem, and so I said, what do I do? Do I leave it? Do I take it out? I said, I'm gonna leave it. So I place one membrane on the palatal aspect, one membrane on the basal aspect, I tax it, and then I place bones. The problem is with novel active, you don't have, you can use a multi-unit, but you don't have anti-rotational bridges. And the only thing possibility you have is on one, and on one is too big for lateral incisor, so and then you cannot compensate for ambulation. So I decided to place a hip abutment, graft rectally and the patient. Let's see, let's wait, and I will probably need another second connective tissue to finalize the case. So this is 3 months later, and I said, well, not bad, I'm happy. This is a can improve the situation, no problem. So I went 4 months later and did the second connective tissue graft on the vocal, the vocal flap to the vocal, and the vocal connective tissue graft from the velocity to the vocal flap, and then graft 360 degrees around my, you can see how deep the implant is, which is, I don't feel comfortable going directly to the implant head and then injecting my circular connective tissue graft around my implant. So this is where I finished. You can see before and after. You can see 4 months. You can see 12 months. And this case has already 4 years. The connection is 7 millimeters away. Something like that. I would have loved to have a trophy contact. So that's why today, when we are going to have a deeper exam, we always prepare the program. And I will show you cases in a moment. These were finished. This is on video when I finished. Palatal, vocal. This is 24 months. This is 4 years. You can see the tissue grew back. Really happy. So let me show you some cases with on one. On one is has many problems, but when do I use transmucosal adaptation? Is when I'm planning that my implant is going to be deeper. When I don't have proximal bone, when I don't have local bone, then I will be using the transmucosal. When do I use an on one? Mainly I use it on the central incisor, maybe a canine, never on the lateral because it's way too big. And of course I will use it on the posterior. Okay. We are clean and novel to come up with the novel active with the N1 connection. N1 connection, you will get it soon, and I'll show you some cases which are nice to look at. Okay. So you can see here N1. Compare N1 to novel active family, which is the novel active family, compared to the N1. So this is on one, this is transmucosal 4.8, the same for a 3.5 implant. As soon as you get to a 4.3 speed, 5.5 will be, you cannot compensate for angulation, you have only 1.5 and 2.5. This is the multi-unit. What is the difference from N1 to active? Active is 11, 12 degrees convergence. This is 8-degree convergence. This is a polymorph. It's a 2.5 millimeter long. So you have less bacteria here than here. You have a smaller base, which is 4.5. You have 2.5, 3.5, and 4.5 height. So it's great for single crowds. So you can use a nice narrow base on a really tightly connection, but the macro design is poorer than the macro design of the non-lattice. You need to be really careful the way that you do your osteotomy on this implant. It doesn't have the same initial stability and you can reach with your stability. It's a matter of playing around. Okay? So the big picture, it comes with an implant, a deeper implant, that means more than 5 or 5. Is that I always use a 2.5 millimeter abutment to 3.5, which has to be deeper. But I always have to think about 2.5. 2 will be the minimum distance for soft tissue grafting. The on one on an NP is 4.8, on an LP is 4.5, 4.3, on a YP is 6.5. You have minimum height, you have to place it palatally, you have to use a universal abutment, which means you have to glue a metal to your zirconia, and this is the problem for your value and have a nice result. Okay? So if you are not deep enough, you will have to confine the soft tissue, and this is something you have to do it yourself. Watch out, all my splinting is not extracoronal, it's intracoronal. I make a hole on the tooth. I don't want this thing to be bumped, especially like her. She's a class 2. I tell her intentionally. My experience with external splitting is that they bond. Why do they bond? Because they have where the composite wear off. The composite maybe was not done on the best situation. So it doesn't, it bonds. So I do a trough and then I place my implant, my cord inside, my wire inside. This wire is 0.18 and the situation basically I want to graft above the implant level to the trouser contact with the surgery, the connective tissue, the trouser, how usually when I have a recession on the rest of the teeth, I do first my implant. I'm not trying to do the recession of the rest of the teeth. You can see the bone is being packed. We want to graft, so you're going to remove all the grafted tissue, and then you place your connective tissue around, so you can have both worlds. The tooth, the soft tissue, we modify the soft tissue, we clean perfectly the inside, we position it. If the tissue moves, we suture it. In this case, we didn't. But you can see that this implant was not deep enough. But we need to also take into account that we're going to bring all the rest of the soft tissue to a more coronal position. So you see that I don't do it at the same time because it's a longer surgery, and then the tissue cannot get exposed. I told you that before. I want to have it pretty much closed, and nothing can get exposed because it will necrose. It will see more problems. This is where we started. This is where we finished. You can see in the second round of connective tissue, I graft the rest of the teeth to level the soft tissue horizontally. I regrafted my implant So you have a second chance to make it perfect, and leave iPhone video finally. Okay? So once we are back, I will show you a case with no vocal bond. This is the one with no vocal bond, no palatal, but still have some bond to really anchor the implant. And once we are back, we'll show you more difficult cases with the proximal bone, how we deal with them, and we'll go in delayed approach and tissue problems and how to get rid of them. So I hope this morning inspired you, and I hope we still have one day to go, and we'll be happy to thank you and see you.